me if not. Thanks for coming along tonight. It's hard to get here, but I really appreciate it. I've got good news and bad news about this presentation. The good news is I'm really happy to be here. The problem with good news is when I get excited, I put too many slides in and too much information. So I've managed to get it down from 120. We'll see how we go. So I think you've met most of us, Matt and myself, as we go along, and of course Justin, who's had a great role as a GP for our military, and we're really keen on finding out who's interested in military police and first responders and their special needs. What we're going to amble through tonight is trauma-related psychopathology, and I think I'd like to get away from the idea of PTSD. There's a lot more to it than that. What do soldiers and coppers do? We're going to talk about the ideal world, and I've been having some good experiences with SAPOL this past 20 years. And when I say that, SAPOL invariably fall about laughing. The ideal world and the awkward ones, and why is compensation such a problem? And segueing into Matt, I want to talk about the importance of the group a little bit in collaborative management, because these individuals tend to be very tribal in the same way that health professionals are tribal. And Matt, I think, is going to talk about what's new and available in South Australia. Now, what I think you think is it's all about PTSD. So just do some exposure therapy and an SSRI and everything will be fine. Sometimes they get their lives back. The paperwork's awful. The rehab providers are pushy. You can't get in to see a psychiatrist, and of course they don't write back. It's fair to ask, has my College of Psychiatrists failed GPs? I've raised it with them last week. They said, don't say that. And I said, sucks. I'm going to say it anyway. I think we have. What we see, shame and guilt, social isolation, disengagement, identity loss, and that's a big one. Anger, to start with. Stimulus seeking, suicide attempts. Stimulus seeking seems a bit weird, but we're going to talk about that later. The paperwork's awful. Everybody knows the paperwork's awful. Marital issues, and I'm particularly pleased to see some EPs here because back, knee, shoulder, and endocrine problems are overrepresented. A lot of our guys wind up obese because of those back, knee, and shoulder problems. Police do a lot of watching and waiting and eating, and diabetes is overrepresented, and police force, certainly obesity. And at worst, financial problems and homelessness. I've got about 4 guys at the moment. 1's in jail, 3 have spent lengthy times in jail because of their experiences overseas. I think it's a simple equation for me. They protect us, we look after them. It's a command and control structure. One of the things as a doctor that I find particularly pleasing is that they do what they're told. They also have a habit of coming back and saying, that idea sucked, sir, give me another one, which is fine. It's nice and clear. They work well with each other, mostly. It's not just fear, helplessness, and organisational injustice are big problems. Try and find out exactly what they do. It's quite interesting. I have a little group of about 6 ex-military police. I thought military police were just nuisances who arrested you when you were drunk and put up traffic warrants. It turns out they do counterintelligence, forensic analysis, including war crimes. Quite interesting as to what people actually do in their jobs. Find out exactly what their family thinks. And think in terms of problems, not diagnoses. Now, I hate standing here. Does this thing work? Oh, cool. Forget evidence-based medicine. Stick to science-based medicine. And we'll talk a little bit about that as time goes on. Evidence-based medicine involves highly selected individuals who get into those studies. In studies of antidepressants and PTSD, the patients who are selected are about 10% of the average clinician's load. They are quite atypical. Where's the camera? Oh, cool. And think in terms of problems, not diagnoses. I think something that GPs in particular are really familiar with. So, PTSD, DSM-5. Everybody knows, intrusions, avoidance, negative alterations in cognition, startle and hyperarousal. All very good. But if you statistically analyse this, you'll find that there are a bunch more problems that are more representative. Anhedonia and stimulus seeking. We'll get to that in a tick. Dysphoric and anxious arousal. Externalising behaviours. Road rage is a biggie. Stimulus seeking and hyperarousal. Why would you do that? Because these guys are trained for this sort of stuff. And the reason they join police and they join the military is because they stimulus seek. The other part of it is that with chronic psychiatric problems, there is a measure of anhedonia, difficulty experiencing pleasure, and there are issues associated with that in terms of management. But it's more complicated than even that, because PTSD in pure form is quite rare. It's nearly always accompanied by depression and often with substance abuse. So if you try doing exposure therapy with somebody with PTSD and they're depressed, you will certainly make things worse. The other issue that comes up is PTSD. The exposure therapy is geared around PTSD being a fear-based disorder. It's generally not. There's a whole bunch of other cognitions that go with it. But this is like the KTEL steak knives ad. Marital and family problems, anger management, identity loss, alienation, compensation problems. As we mentioned, musculoskeletal problems. Many of you are GPs and are quite aware of thinking in problems, but those are just some of the headings. And then we get to the question of why is it so? So all patient descriptions here have been, the patients are happy to be described. He's not Lieutenant Tom. I picked that because of Major Tom, which he was at one stage as well. So Lieutenant Tom spent some time in Afghanistan, and he was referred to me for initial management to see if he was fit to stay in the army, and we succeeded. He saw service in Afghanistan, he killed some people, he had his troops kill a lot more, and his opening comment was, "I've lost my moral compass." He had the usual nightmares and dissociative flashbacks, and as we talked, one of the issues that really came up was the part of ourselves that is rageful and angry. Very useful if you have a home invasion or you need to deal with hospital administrators. And we talked about that he had that feeling of being out of control, that this thing inside him was off the hook. So he was frightened of keeping his job, but he was really frightened of losing his job, but he was frightened if he was keeping it, that maybe he would continue to be a killer, and even worse, that maybe he'd lost control, maybe he'd started to enjoy killing. And this started to rattle around in his brain. And as a killer, of course, you're not going to have many friends. So he's going to be alienated and rejected. So why is it so? Now, these are just some of the networks in the brain, but here we're going to focus a teensy bit on the, whoops, what have I done here? The fight or flight network, and I'll complicate it later. So over on the left-hand side, we have the amygdala, which everybody knows, walnut-shaped piece of tissue sitting in the temporal lobes. It picks up fear-based information, disgust, well, really that's olfactory tubercle, and a whole bunch of other things. Then we have the ops center. How do I get out of that? Help. So I'll get that fixed up while we're talking. Over here, we have the locus coeruleus, which is where most of the brain's noradrenaline come from. It's about P-shaped, it sits in the midbrain, and it pumps adrenaline backwards and forwards through the brain. Then over here, we have the anterior cingulate, which is tucked in just inside there, inside the sulci, and the hippocampus. Now, the way this system works is, let's say we have a Bengal tiger coming through the back door there. All of the information about the Bengal tiger is going to go to the thalamus and be routed in two different directions. The first place it winds up is here. That's got three main interests in life. Can I eat it? Can it eat me? Can I have sex with it? It realizes that it's big and angry and orange, and only option one, I can't eat it, it can eat me, is valid. Goes to the locus coeruleus, which starts pumping out adrenaline, lots of it. And that adrenaline rattles down to the body, moves our skeletal muscles into fight or flight mode, tenses them up, hence all the aches and pains, pumps our heart full of blood, and makes our pulse rise. Meanwhile, this has picked it up, and it says it's about 300 kilos, black and orange stripes. We saw one last week, and we hit it with a brick. By the way, I think this one's a boy, might be a bit friskier than the girl we killed last week. Having sent a message down to the hippocampus to get that information. When you have too much charge going through these circuits, you have a whole bunch of other things happening. This turns that off. This turns that off. So you find difficulties organizing your brain, setting a narrative. You find difficulties with memory. And one of the ways this is assayed, which is really interesting, is they used to use faces, a paradigm of faces, 30 faces, 10 happy, 10 neutral, 10 angry, to elicit the emotion. People with PTSD and depression always see people as much more angry and mean than they actually are. And of course, if you have that feeling about things, then people are going to behave and treat you like that. So things don't work out so well. Of course, it's more complicated than that. We have a bunch of other networks. The ventral salience, which is our kind of body's janitor, our gatekeeper, it starts to break down as well and lets too much information through. And that's why pain is increased. The other part that's affected is the default mode, which is our experience of self. It's centered in the precuneus, which sits about here. And one of the issues that you find with patients with trauma-related pathology is that they start to experience lots of flashbacks as they let that go. Yeah. Now that's him as he is, or that's how his kids see him. But there's no doubt he's still a sheepdog. He's certainly not a Pekingese. He's been able to control what it is inside him. So stage one, when we start to see these guys, age 20 to 40, lots of anger, perplexity, stimulation seeking, wandering into the Smithfield Plains hotels and shouting, "I hate bikies" on a Saturday night, that kind of thing, getting themselves into strife. Over time, we move into nightmares, dissociative flashbacks, avoidance and panic. And what we don't want to see is the 50s, anhedonia, chronic inability to experience pleasure, shame, guilt, and chronic avoidance, usually plus or minus substance abuse, at least cigarettes, often alcohol as well. So really what we're trying to do is get involved here when they're just cranky. And that's something we've been doing this quite well this past 10, 15 years. Yep. That's all right. Okay. So online people, stage one is anger, cranky patients. Stage two is the anxious, dysphoric patients. And stage three is anhedonia, inability to feel, inability to experience pleasure. Got that? Now, there's a few other things to think about with these guys, is duration. Now, we're conscious of PTSD and trauma-related pathology in military, but military deploy for 6 to 12 months, sometimes longer. Police are deploying constantly. There's a constant level of stress. Fireys are deployed when there's an event. A lot of the time they're sitting around for something to happen. Community visibility is very high in police. They are also the face of our government. So whatever wishes we have about the way things are going, the police are there. Community affiliation, very low in military. They tend to move around a lot. They tend not to have a lot of friends in the places they're posted, except for other military. Command visibility is another one. I was always told the casualty rate in officers should be higher than that in men, but not so in the Australian Army. Or police for that matter as well. And social support and stigma. Better than it was, but still not great. Now we talk about moral injury and helplessness as if it's a new thing, but this has been a part of our experience with these individuals for many years. The types of things that you see that you can't do anything about. So horror and injury, predictability and control. How much is this predictable? Usually not a lot. Objective danger varies. Capacity to react varies. Bullying and organisational injustice. Lots of envy, lots of internal games can be played, which can be very awkward. Sexual abuse and harassment issues, unfortunately, still persist. There's a number of rape victims that we're seeing ex-military. And the effects on families, anger and control. Dad's got PTSD, dad's become a non-person. How does that fit into this family story? Now, who are our soldiers? Most of our understanding of PTSD was based on high-tempo warfare in World War II. We haven't had much in the way of high-tempo warfare with jets and cannons and stuff, except for Gulf War I and the start phases of Gulf War II. A lot of our guys are attached to other units, Bosnia, Africa, various missions that can't be described that actually did happen. and support individuals based in the Middle East area of operations, which is one of the Emirates. And the issue there, not a lot of objective danger, but some, particularly if you're female, very hot and usually 18-hour days. So they come back fairly stressed. Remote warfare units, for example, drones, there's issues associated with that because you're following an individual around for a while. You're kind of aware that he's not a very nice person, but then you have to blow him up or somebody blows him up. And border protection. One of the issues with border protection is the number of boats that are sunk, the number of boats that are known that are going to be sunk and that you can't find. And it's been mentioned to me the number of sharks in the Indian Ocean, which some of our guys have watched. Now, the other thing to think about is 200 grand to train a rifleman to a very basic level. If we have a ground war, it won't be those guys we're sending out. They will be the guys that are training the rest of us. And so they're like the B memory cells of our defence. Now, when they come back to South Australia, let's say post-discharge, they're reconnecting with people that they might have known. Their lives have moved on. They want to re-establish friendships. It may or may not work. They disengage with their tribe. There are various social media groups that work with that, but they tend to disengage. And often if they're psychiatrically unwell, they even disengage from those things. They cut themselves off. There's a preoccupation with DDA and claims and the confusion that goes with that. There's an attempt to re-enter family life. And often they've been away, going backwards and forwards. From their partner's point of view, it's going away, having fun in the bush, racing around, doing things, or having fun in Afghanistan. Kind of, I don't think that works, but that's what people can think. And an anger at the responsibility for the family that hasn't been there. Now, you often see a restless pattern of employment and activity, and AIB, which is Pawlowski's old term for abnormal illness behaviour. In this case, it's illness denying. Nothing wrong with me. I've changed 3 jobs in the past 6 months. I drink like a fish and I like to use amphetamines, but that's perfectly normal. And a lot of these guys pop up in all sorts of ways through GPs who are known to have a military affiliation, and they'll literally pop out of the woodwork and get referred to me. I've got 5 patients in Mackay, for example, who've gone through exactly that pattern. Very often, soldiers discharge from the military without taking a medical discharge. They come back from service, they're angry, they get angry with the military. Garrison service is quite different to wartime service. And they'll potter around for 4 or 5 years, very often getting themselves into trouble, compromising their marriage, etc., before they pop up for treatment. Not an uncommon pattern. And at worst, homelessness in jail. And here we run into the issue of who did what to who. One of my favourite patients, Maddie, is currently in Mobilong, following a car chase during which he went and tried to find intelligence in Kilburn. I suggested there mightn't be much chance of that. There were a few assaults and a few other bits and pieces. He was handled very badly after he left the military, who gave him a lot of opiates for his back pain. Opiates are great for PTSD as well, so he kind of liked them and then moved on to heroin. Very nice young man, mostly. I remember at one stage he'd come back to hospital and he'd made a series of blunders. We were going to have to discharge him. And I said, well, look, Matty, let's see if we can get through one night without having a problem. One night only. And then I thought about it and said, Matty, have you got any weapons? And you know how Doctor Who does that thing with his pockets? There are about 6 knives in there. So Matty's currently in Mobilong, but as a machine gunner in Afghanistan, you'd like Matty by your side. And Matty didn't start off like that. And the other thing that you see is physical injuries catching up. Lots of musculoskeletal injuries. These guys carry big loads, 40, 60 kilos. If you happen to fall down because you're getting shot at, you will not fall down in an ergonomic way. Lots of injuries to knees, lots of injuries to backs and also shoulders, which is where the EPs come in, because one of the things I see very commonly is cartilages being sliced away and then a declaration at age 45 that you need a knee replacement. So very useful to try and rebuild what's left. Now, marching on, it costs a lot to train a policeman too. Curiously, when a police car goes on a high-speed chase, it's serviced immediately afterwards. It costs a lot more to train a policeman. So when you're dealing with these individuals, the community has paid out a lot of money to build this piece of kit. Now, we're going to put them in harm's way. That's fair enough. That's what they do. but then we need to maintain them if we're going to preserve that asset, let alone the human cost. Now, there's a few things to think about with cops. Uniformed and CIB. Now, uniformed tend to be on the front line. So if they're doing general duties, that's where the fights happen, that's where things are thrown at them. So there's an obvious physical danger. The trouble with CIB is they get to delve very deeply into the lives of the victims. And so they get to know the victims, they get to know the families. And so that becomes quite traumatic in its own right. And one of the patterns that you see, usually in about the 30s, usually when the guy's had his first kid, that he'll move from CIB back to uniform because he can't deal with that sense of loss, that sense of confrontation. And also when you've had kids, your life is not your own anymore. And so you find individuals becoming more nervous, more risk averse. And then there are subspecialties. General patrols, they will vary with the socio-demographics, the level of danger. Major crash is a great one for causing people issues. And the problem you have with these types of high stress organisations, child and family violence and undercover in particular, is you've probably got 5 or 6 years before it starts to significantly psychologically affect you. The problem with that is that you're probably only really up to speed after the first 2 or 3 years. So from the organisation's point of view, they really only have an asset going for 2 or 3 years. Plus individuals find it fascinating and they want to keep going despite the fact that it's difficult. So these are challenges industrially, organisationally and personally that are not always that well dealt with. Undercover cops are interesting because they tend to have to identify with guys on the other side of the law in order to maintain their cover, and moving back into general policing can be awkward as well. Country stations, less problematic than they used to be with the absence of single country stations, but there are still some low levels of police in country stations. The difficulty there is that you tend to be on call for 24 hours. And as one of them put it to me, the accidents are at higher speed, there's more dismemberment, and you usually know who's been involved. So there's a closeness with that. When we moved into our small country town, the Adelaide Hills, one of my wife's first acts was to certify off and work cover our local policeman, which means we don't have a cop there anymore, but he really had put in the hard yards for many, many years. What's on the side? We handpicked them. We handpicked our best and brightest, IQs of 90 plus, a higher level of fitness compared to the general population. There's a strong sense of tradition, esprit de corps, of belonging, almost a corporate wisdom about how things will go in these difficult, dangerous and frightening jobs. The units are very tight, unit cohesion. One of the things that the Americans found puzzling at the end of World War II was that German units kept fighting in small units, and this was because of the tight camaraderie that those units had. Leadership. Leadership can be good or it can be bad. And repetitive training. We don't rise to the occasion, we sink to our training. And that's another thing about these groups. They're regimented. They like doing things in systems. They like doing things in an ordered way. Can be very irritating to be around, but it can also be, in high-risk situations, extremely comforting to have people who do things that way. And I've never met one yet who didn't feel protective and altruistic. That they join, they say they join to make a difference. There's usually a family military history. Sometimes there's a personal exposure to soldiers or police in some ways, and they're often country kids. But the purpose of life is a life with purpose. And that's really something very powerful and profound for them, which makes it difficult when they move out into veteran status. One of the things we've been particularly pleased with the police, and we'll talk about this later, is the ability to actually move somebody from, say, psychiatrically ill in hospital back to operational duties over a varying time period. And physical fitness. Very high in the Army. You have to do a brief fitness assessment every year, which is age-based, not tested at all in police, which I find interesting. I don't think it's tested in the AMBOs either, except for the intensive care paramedics. Enemies. Helplessness, horror, disgust are their daily jobs. There are significant consequences of error. I haven't mentioned there's a high degree of monitoring. Police are always being monitored and scrutinised. The rows of mobile phones and scanning of incidents as they are occurring, guys wearing body cameras and other cameras, constantly being monitored. Organisational injustice, quite profound in these very bureaucratic organisations and still occurring, and a major issue. Command and its visibility. Send me another one, that one's broken. That one can't do this, just get rid of him, find me another one. You've just sent 200 grand of the country's money down the tube. Thank you, sir. Shift work with all its eruptions. Corporate knowledge, and we talked about that with major crash in some of the organisations. Just when somebody's getting up to speed, they're halfway to burnout in some of these units. And expectations. Is it a job, just something we do, or is it a life? Is it a career? It's a profession. It really is a profession. Now, we're getting into emerged services. In this state, the presentations, at least to our group, are standard private, where it's just managed as a normal patient. Sometimes there's occupational stress as part of that presentation, but they don't want to go on work cover or work cover itself. As you know, with the Return to Work Act for mental disorders, the phrase "the significant cause" is used, and that means all other causes, according to the lawyers, must be trivial. So that's the thing to get your head around. As I've mentioned with police, it's been pretty reasonable. With work cover, there's a 2-year income maintenance, but your operational loading is cut. The last patient I saw is currently on $90,000 a year as a senior sergeant. With all his shift work and operational loadings, he would have normally been getting $140,000 to $150,000 a year. So when they shift into a compensation setting, there's financial burdens that kick in as well. That gets to be an issue. Entitlement to income maintenance indefinitely. I'm pleased to say the AMA and really lobbied government with the emergency services guys for them to have access to long-term workers' compensation if they became unwell. Lobbied with the Police Federation and a few others. And fortunately, despite the fact that that law came into place about 3 or 4 years ago, the courts haven't quite worked out how to deal with it. And there's a bunch of cases before the courts which are creating tension for individuals, usually in their 50s with long periods of service. Now, how do things go? Today, I sent somebody back to work. I was really happy. 10 weeks ago, on a 24-hour period, I sent 3 blokes back to work as coppers. It was great. It was a good day. Usually, there's a referral via the union, the GP, police wellbeing, and injury management. Very often, all 4 or 5 of them once. So there's a sense of looking for a group that will help. Psychotherapy, our group uses a lot of ACT therapy. There's nearly always a trauma focus in the therapy that we do. We do go through little bit by little bit exactly what happened. I like drugs, so I use a lot of medications and I work with a whole bunch of competent psychologists and psychotherapists, and so they do a lot of the therapy stuff. Then we have a return to greater duties. What we're looking for there is minimal exposure to offenders, usually in the office, usually doing the work that no one else wants to do, which is kind of handy because you're immediately back in the team doing something. Then as we get the IMOS test done, the IMOS test is dealing with situations in real time, firing weapons, using tactical options, and a little bit of unarmed combat as well. It's a really great way to monitor somebody's reaction to stress. It's a really great way to monitor, in particular, their anger control to see whether they've still got and their startle response. When that's been managed, we usually start sending people out to the front desk. At this time, they're armed, and we start sending them out in a vehicle with another more senior officer, and then back to solo or group patrols. Now, that process can take anywhere from 3 months to a year. And during that time, we're monitoring backwards and forwards as to what's happening. One of the guys that I see, who was ex-CIB, now patrols, one of the things that really tipped us with him was that he was able to deal with a pub incident where he had 3 drunken individuals yelling at him, in his face, telling him what a pig he was. During that period of time, he maintained poise and demeanour, and we thought, okay, you've made it. We're going to be able to send you out into operational patrols. So what we're looking for is the level of stress, confrontation, horror, and disgust that they're encountering on a day-to-day basis. It's rough, but life is rough, and life is to a large extent unpredictable, but so far it's seeming to be working. And of course, then return to work, everybody claps each other on the back, good cricket all round, and everybody goes home. Unfortunately, it doesn't always work that way. If Internal Affairs or ICAC get involved, and anything that a policeman does that could look criminal, Internal Affairs have to get involved. Then the matter will be problematic. And one of the particular issues there is that one of the ways that your angry, developing PTSD or depressive copper will behave is he will do something reckless or dumb and get himself in harm's way and find himself dealing with these individuals. Unsupportive command. Now, I haven't got that there. I'm looking after a bunch of people at the moment who were accused of theft from a drugstore, from a drug house, probably 7 years ago. Their trial at a cost of $30 million went on for about 7 years. They have $2.1 million in legal fees to pay back. They were found not guilty. So there's a bunch of issues that like that float around. Unsupportive command. Now, pleasingly, one of the cool things about the cops that I found is that within 3 or 4 weeks of seeing that particular policeman, I have their command, injury management, on my front door, wanting to have a case conference and talk about what they can do. Those are the good ones, and that often happens, and that really means a lot when we start to structure duties. Of course, our job is not to tell them what they have to do, but to give them the broad outlines and try and synthesize together what way of getting the guy back to work is going to be practical and feasible and possible. Bullying, sexual assault and harassment issues, they still occur. Males and females working together. The idea of the alpha male who's powerful and aggressive. Alpha males aren't actually powerful and aggressive. If you read the initial stuff on chimp biology, alpha males actually protect the group. They beat up offenders, but they also protect, look after, nurture and care for the group. So that whole term has been misrepresented. Marital issues. Now, as GPs, one of the things that I think you'll find, if you probably see, is that it's often the wife who presents. It's often the wife who comes in and says, look, so-and-so has been with the police for quite a few years. He's getting angry. He's drinking a bit too much. He's just playing computer games all night. And how do you engage that individual? I guess the usual thing that I talk about is when I meet somebody is to mention that if these problems weren't real, then I would disappear in a puff of smoke because nobody would have bothered to invent me. And I also talk about the history of these conditions. They've been described for 3,000 or 4,000 years. There's a huge litany. Every military force that ever gone into battle has taken between 10 to 40% psychiatric casualties. That is, soldiers who cannot, will not, or should not fight. The 40% is from the naive American troops landing in North Africa in World War II, and the first guy they had to face up to was General Rommel, who, as you know, was quite famous, so that kind of didn't work out so well for them. There are a bunch of other factors involved in that. Then you have, as GPs, rehab providers who don't communicate, and of course, psychiatrists who don't communicate. I communicate exceptionally well, mostly. Then you've got the other awkward ones. You have a lot of trial by media. We have a whole bunch of interest in veteran suicide, and there's been a lot of them, way too many. And it's kind of odd because in 2000, when we went into East Timor, Blind Freddy knew what was going to happen. We were going to have a whole bunch of psychiatric casualties coming out of that. So where were the systems to deal with it? I know me and our group were talking about this back in 2005, 2004. We've got war crimes and trials by media. Royal commissions, this famous Sturt 6. Then you've got physical injuries complicating the psychiatric. Probably one of the toughest cases I've had was a guy who presented with a back injury and he'd fallen to pieces. Nobody could really understand it, except he was at the infamous massacre at Kigali in Rwanda about 10 years beforehand. What had happened was he dealt with his feelings about that by prodigious levels of exercise, going on every course he could and drinking like a fish. And with back injury, that's when things really started to fall to pieces. He's done quite well in time. And some have found Comcare and the Australian Government Solicitor difficult to deal with, or anything connected with the Administrative Appeals Tribunal. In fact, we found them so difficult, we refused to deal with the Australian Federal Police or our security agencies at all. And I'm happy for that to be repeated. Now, all military related conditions should be assessed and accepted before discharge and eligible for treatment under DVA. All medically discharged veterans should receive a Com Super A class pension. Incapacity payments continue for some, and rehab providers keep in touch with their treating doctors. This is the ideal world, but as you imagine, it doesn't always happen. And sometimes you've got to jump up and down and make a bit of fuss to make sure that it does happen. One of the cool things that's happened since the 2016 Senate inquiry was that a lot of soldiers now are being evaluated. All of their DV stuff is sorted before they leave the military. They know where they stand to a reasonable degree financially. And then there's a transition to involvement with rehab providers, some of whom are very good in terms of linking with the docs and heading people off into a particular direction. And as you'll appreciate, there's quite a bit of weight to carry around. But again, when we're talking about what soldiers actually do, it's pertinent to point out that that is a Carl Gustav rocket launcher, and infantry tend not to carry that by themselves. And that, I think, is a sniper rifle, and it weighs about 4 kilos more than the average rifle. So again, dig in a little bit, find out what guys actually do. Is that right? Is that a sniper rifle? It looks like a sniper rifle. Now, when we're dealing with medical legal issues, these are the kinds of things that come up. And I'm sure you've seen reference to personality issues. I'm sure you've seen false information, stories colluded, sometimes surveillance, harassment and threats. And there's a whole bunch of literature about the effect of medical legal involvement. But actually what you're not looking at there is got nothing to do with compensation. It's the field handbook of the German secret police. This is how you set about stuffing people up. This was a program that was operated quite successfully between 1978 and 1990. Allegedly some 3,000 suicides. So if you have a dissident who's causing you grief, you can torture him, but then you'll piss off everybody else, or you could shoot him and then you can make a martyr, or you can quietly drive him mad. Very effective, apparently. These processes are replicated in the legal environment, and there's a whole bunch of data to support the notion that they make people a lot worse. Now I'm going to have to speed up a little bit because Matt will want to talk, so I'm going to start talking a lot faster. So here we have Sergeant Fred, and Sergeant Fred is a country policeman, and he's a very good country policeman, and he knows his town, he likes his town, lots of people, lots of dead people, lots of injured people. And there he is in a country town, which is a major route, and he finds that there are more and more traffic deaths, and he's a good country policeman, so he knows how to set up roadblocks and aggressively bust a lot of truck drivers so the word spreads around, and he runs around in a fury of skill trying to stop people dying. And it doesn't work. And he's referred to me by his GP, who he's known since he was a little kid, hypervigilant, not sleeping, dissociative flashbacks, the whole catastrophe. He was not at all pleased to see me as a psychiatrist, but we eventually got on well. But he made his feelings about mental health and psychiatrists and what was going on pretty well known at the start. So, Sergeant Fred, one of the things that helped was that explanatory model, that same thing that I've run through you. The idea this is not new. Your brain will change. Your police training, your army training will change your brain. Your service will change your brain in ways that are good and ways that are not so good. We gave him some meds, anticonvulsants, and an SNRI in his case. We won't talk too much about meds, much as I'd love to. Trauma-focused therapy, reframing and acceptance. Sometimes the bad guys win. Sometimes the devil wins. Sometimes you can try all you like, but it's just not going to stop it. That's the way it is. Year one, he spent some time at the academy, refreshing his police skills, realising that he still had them and he was really good at his job. And we sent him back country policing, and there was a bigger station, so less solo work. About year three, it's not mentioned in there, there was a traffic accident. He badly smashed his foot. It wasn't his fault. It was the guy who was driving the vehicle. He went back onto duloxetine at the suggestion of his GP, popped in to see me to make sure it was okay. I said, fine, that's good. I'll see you in a month. Once again, he started a pattern of non-attendance. I suggested that maybe I'd become redundant and he should go away. Year seven, he came back and he was having a recurrence of nightmares. Now, this particular one involved a young girl who died in his arms in the bush with a head injury. He was still having those nightmares. except he'd recently married and the girl's face was morphing into his wife's face. Nevertheless, he continued working. We started him on some medication. He started to hit the grog. We managed to curtail that and he kept working. Year 10, he was assaulted at a nightclub. I think he was smoking. The bouncers moved him outside. He raised his fist. They took him outside. They beat him up. Oddly enough, he was found guilty of assault and asked to leave the police, which was, really disappointing, like very disappointing. Nevertheless, that guy with a very serious illness, we should have hospitalised him at the time, was able to function. And again, the issues that came up were the use of the academy, the low-grade duties, forming a good relationship with his treating people, and a lot of support from injury management to find him greater duties and gradually build up his stress tolerance and increase his confidence in the process. Few thoughts on management. I had a lot of trouble finding all the 8s to add on to this, but just easy to remember. Ventilate, let people talk. I usually say, look, I'm not going to talk to you about what happened, not that I'm not interested, but I'm usually the 3rd or 4th person they've seen. So we'll get to that when ready. But as a GP, you'll need to know your patients. They might need to come in with something emotionally, very pressing. Validate, yeah, that was a horrible thing that you saw. That's going to have an effect on you. Educate, this is the kind of thing that can happen when you have horrible things happening like that. Stress management, the usual sort of stuff. Elucidate, and that's a fancy word for when things have settled down a bit more, just digging a little bit into the details of the trauma, because often it's quite, more detailed and more surprising than you might think. I can't think of a particular police example at one stage, but I remember seeing a guy many years ago who had headaches from his head getting caught in a lift. No big deal. You'd think. Turns out it was a mining lift. Nobody had ever tapped into this. One of those big things that carries about 100 people, and it had come down and it was squashing his head against the ground. So there was a fair bit of trauma and anxiety mixed into that. So it helps when the patient's feeling calmer and trust you just to dig in a little bit, perhaps even quite a bit, into what they actually felt or thought at that time. And don't be scared to medicate. The Phoenix guidelines, the second to last, said use an SSRI, do exposure therapy first. That really wasn't a very good document. The last Phoenix guidelines I'd commend to you. They talk about a range of medications for different facets of the syndrome. They talk about the different psychotherapies that can be introduced. And that double-blind evidence-based medicine versus science-based medicine, I could go on for some time, but we only have a little bit of time today. Oh, the good news is there's another seminar coming up in August the 14th, which I hope some of you will be able to attend. And then we'll be able to dig into lots of subjects about this. The critical incident is that people go looking for similarities. If you got mugged by that Bengal tiger coming in through the back door, it won't be long before you're frightened of chairs because chairs have 4 legs. The amygdala goes looking for similarities. Has anybody had dealings with horses? Yeah, my wife's got horses. One of the things apparently they don't like is they don't like any change. Anything that reminds them of something else freaks them out. The problem is, evolutionarily, we started out as prey animals. We still have those reflexes for danger built into us. The other thing worth mentioning is the only reason we took over the planet is because we learned to work in organisations and groups. And that taps into the issues about bullying, because with bullying, you are being excluded from the group, and that is a danger signal for social primates like us. So look for the differences, not the similarities. I use Kermit a great deal just to illustrate that point, because you can't look at Kermit and not feel happy, and people seem to like that. Stabilise and make safe. Create a safe environment. This is the space that we're going to discuss some of this stuff. We're going to leave some of this stuff here. Medications are as a brace. Medications don't get people well. What they do is they stabilise important bits of the brain so that the person can start to rebuild the brain themselves. And there's a whole bunch of stuff about neurocircuitry that I could talk about, but we won't. Family. Make sure the family knows what's going on. And then you have what Mnuchin called structural issues. Suddenly you've got a guy who's a psychiatric illness, he's an invalid, and his wife becomes a carer. What you want is for him or her to go back to being a parent and partner. All very well. But the problem is the carer, who's been so used to looking after the invalid for X number of years, will feel nervous about that, may even resent that change in role. So that's a transition to be managed as well. And exercise can be compromised by pre-existing injury, and that's where exercise physiologists come in. Now, the fact that I've been seeing one for 7 years and the fact that my son's training to be one has got nothing to do with that statement. I actually have seen it work. Now, the other thing is timeframes. Soldiers, police like benchmarks. They like things to aim towards. You may get it wrong, but it does help. And there is actually literature that suggests that if you're dealing with return to work programs, if you set a time, the outcomes tend to be better. Re-engage with the tribe or the workplace and monitor threat and confrontation. That's something we talked about beforehand. A couple of little tricks when I'm sending people back to work is I get them to have very sugary drinks. That feeling of satiation is accompanied by your brain pumping itself full of endorphins, and the physical handshakes actually produce a little bit of oxytocin. That's science-based, it may be voodoo, but it's something that I usually recommend that people do. And one of the things that came up, and I was talking with the dude who reformed work cover over the weekend, Greg McCarthy, there is way too much focus on liability in all compensation schemes. Compensation is about getting a life back. It's not about money. And so liability is something that the courts take ages and ages. It really is a waste of time, but that's a separate discussion. Now, relapse monitoring. From the horse's mouth, watch your sleep, watch your friendships and activities. Are you avoiding them when you're managing these guys long term? Are you having fun still? This could be controversial. If your partner says you're not well, you're probably not. There's all sorts of reasons why your partner says you're not well, but as a rule of thumb, that's not bad. Two-shot Darrell, I think, is fairly straightforward. Sprinkler is so named because of the 8 bullets he got him hit with as a probationary constable, so that was his police nickname. Despite the issues with that, he behaved in a tremendously counterphobic way through his subsequent 20 or 30 years of policing. If there was a bikie to be arrested, if there was a door that needed to be broken down or something there, then Sprinkler did it until the age of about 54, 55, when it gradually started to fall apart. But fortunately, Sprinkler's doing quite well. In fact, he discharged him a year ago. Now, this is building into Matt. I couldn't find anything particularly about PTSD. But notice here with treatment-resistant depression, this is from a tertiary institution in the UK, strong social support, low levels of relapse or lowish. This is treatment-resistant depression. These people who haven't responded to other things. High level of social support, low level of social support, which is sometimes induced by the condition itself because people start backing away. Then the relapse rate increases, which is why it's really important to have these kind of tribal groupings, which Matt's going to talk about. And I've been personally very stoked to see build. Now, I couldn't find anything particularly about PTSD in group programs, although I should have asked John Lane, who's been running an awesome one here. But in the war in Eastern Congo, which is sometimes called the 5-Nation War, 30 million dead so far, apparently. Lots of rape. Lots of other horrible things. They sent some troops in with some clinicians there very bravely. They didn't do exposure-based programs or discussing the issues. They just talked about general stress management stuff. And they found that the effect of the group therapy was significantly better than individual work. And from an NGO point of view, that's much more cost effective. Now, as we're moving on, medications, squillions. And something that's quite interesting, MDMA, there is actually good solid data for it. None of these things you should think about doing yourself. I've certainly used buprenorphine with patients with comorbid pain and PTSD, and the outcomes have been spectacular. And yes, drugs of dependence knows all about it, and they're quite happy with it. Ketamine, psilocybin, but all of these things are a long way in the future. Now, your GPs. And I'm aware the paperwork's intense. And I'm aware that there are a lot of things, some of which you don't get paid for. So here's the thing, if you're dealing with rehab providers at the outset, if they want you to coordinate this, then you should tell them and tell their company, this is the amount of money I think it will take, and you should put a bid in from the get-go for that amount of money to be guaranteed to you. I'm told by Craig Rivett from DVA that this is the way it should be. Because if you don't have somebody in charge, you wind up with a situation like that. And from a specialist point of view, actually managing a lot of this stuff with good GPs on board who are communicating with me backwards and forwards by email or whatever makes life a lot easier and a lot more effective. So, know the mission, know what happened. And if it's classified, just don't write down where it happened or when it happened. Assuming you'll be told in the first place. Try and pick up the problems early in the lifespan. Anger is an early warning sign. Ventilate, validate, etc. Everybody remember all the 8s? Yep. Okay, I had to go through a thesaurus for that. Get the family involved. Psychoeducation at the least. They need to know what's going on. They need to know the doc's taking it seriously. Stay on top of what's happening. And despite what adversarial lawyers might say or insurers might say, stick to the medicine. Best advice ever from Dr. John Cross. And with the paperwork, just make sure you get paid. Now, we're having some more of this. Matt's going to talk about it. I will shut up in a minute. And these are the people that are coming along. There's a really cool movie with me in it on the web. It's said that the producer of the Pink Floyd album Dark Side of the Moon was offered a percentage of the take. He refused it and took a flat fee. I'm kind of wishing I'd taken a bit of the take as well, but never mind. Thanks for listening, guys, and we'll hand over to Matt.
Thanks, Nick. Is everyone okay just for me to push on, or would you like a minute, toilet break, water? No, all good, keep going? Excellent. Stole the clip. Get this out of the way. Cool, that's me, as you would imagine. I'm not going to go too much into my story. I think Nick has explained a number of quite key examples already this evening. But to give you a bit of context as to how it is that I did end up here, I was in the police from 2006 until 2016. Most of my roles, as discussed in the introduction, were around the general patrols, plainclothes duties. I did some stuff in the proactive teams as well, dealing with some outlaw motorcycle gangs and some low-level drug crime. But ultimately, I liked being on the front line. I like catching bad guys, driving fast, doing all the cool stuff that I thought was in the brochure for the police. So all of that does exist. There's obviously also some additional stuff that goes with that. Early in my career, I think within the first couple of days, I had seen my first dead body out in the public, so to speak. I then went on from that for the next probably 7 years, being exposed to quite traumatic experiences, anything from deceased children to dog attacks to people pulling weapons on me, for me having to threaten to take other people's lives for not only my safety or maybe others, and a whole range of other things. Not only with the traumatic experiences though, there comes a lot of the environmental factors that go into being in the police, or certainly in the military and other emergency services. It wasn't uncommon for me to have to work overtime, often out in the cold, it's raining, you don't get meal breaks, you don't get toilet breaks. We sign up for that, and there's a need for us to do those things. Now, humans are very good at tolerating very high levels of distress, providing we have context. So when you're in the police and in those team environments, being in a group and understanding where you fit in that order makes perfect sense. The issue for me came is when I started to disconnect from the meaning or the purpose in which I was trying to do my job in the first place. I started to see repeat offenders. My victim today was my offender tomorrow. I started to lose sight of what it was that I was actually trying to do on a day-to-day basis. The other significant contributing factor was in 2013, my friend and colleague, he took his life. I was working that night. So I also had an obligation as a police officer to manage the scene. But now I had a very real connection because it was my friend now that had taken his life. That sent me on quite a significant spiral over the next 18 months. All of the things that Nick has explained in his slides is me to a T. Alcohol abuse, certainly seeking a lot of stimulus. And again, I won't go into too much detail about my story, but I did find myself in a very ordinary spot, having committed a criminal offence. And the first time that I told SAPOL that I was struggling was 7 months after I'd been diagnosed with post-traumatic stress and depression. There was no way I was going to say anything to the organisation, which I believed would then punish me in some way. And that was a perception. I'm not necessarily saying that that's the truth, but it does happen a lot, not in every case. 2016, I was pushed out of SAPOL and found myself not only with a professional crisis, but an identity crisis. I'd wanted to be a police officer since I was 4 years old. And I think with a lot of service personnel, many have assigned themselves or set those aspirations to join that job at a very young age. They aspire to it. And so at 31, I'd wanted to be a police officer for most of my life and had been one for about 9 years at that stage, 10 years. 2018, I had done a bit of work myself. I then found the road home through a friend and enrolled in the STARE program, which Dr. John Lane has created. We'll go into that in a moment. I did the program as a participant, liked what it was about. It was led by peers. I'll touch on that in a moment. So I decided to stay and I volunteered. I was now working full-time in business development roles and found connection other ways, but certainly wasn't living a life of meaning. I continued my volunteer work until 2000 and, well, actually it was last year when MESHA was formed. We rebranded from the road home over to Military and Emergency Services Health Australia. And I think they got to the point where they just gave me a shirt and said, we better start paying you because you won't go away. Military and Emergency Services Health Australia is primarily a research institute. We have about 35 to 38 different projects that are currently being researched by colleagues like Holly over here. We've got the executive director is the Associate Professor Miranda Van Hoof, who leads the team. But not only do we research, we also train. Holly runs a training space for students who are going through university, either in honours, masters and PhD levels, and are looking to extend their skills into the veteran space as well. So that's a really great program. And then I sit in the service delivery side of things, which is what we'll touch on now, because it's all well and good for us to come up with these, we know that there's issues, but what else can we do about it? And if we're going to say that we need GPs to get involved, I think it's only fair that we try to give GPs ways or other ways that they might be able to help support the people that they're trying to support. We are a charity under the Hospital Research Foundation Group, which means we're independently funded. So when you buy your tickets for the home lottery and that sort of stuff, know your funds are going to helping people like myself and Holly do the work so that we can offer it either free or heavily reduced cost to the people at the front line. There's 3 particular programs that I want to talk about this evening, which is our GEARS program, Story Right and Mind Right. Now, GEARS is the Group Emotional and Relationship Skills-based program. We'll go into a bit of detail, but across those 3, fundamentally, we know that they work because they're peer designed and peer led. They're done in a group format. So we've got the lived experience, not only often of service culture, but also people like myself who have maybe navigated their own mental health journey as well. The transdiagnostic. We know that PTSD is a thing, but we've found great success with these programs also in other issues such as anger, suicidality, substance abuse, anything else that sort of plugs in, which Nick was sort of discussed in his slides there as well. Another important part is the functional skills based. We're not necessarily looking at the symptoms. We're looking at helping upskill or offer tools and strategies for the individual to start taking a little bit of control back in their life. What we're finding is a symptom reduction as a result. And when I say collaborative approach, that's pretty important. To get on the GEARS program, we ask for a GP referral or a health professional referral. Again, we found ourselves in a position that if I was asking military or emergency services members to get a GP referral, they were then asking, well, which GP do I go see? Which GP can I trust? It's a great question. So I go to Nick, I start saying, which GPs would you recommend? Here we are. The important part about the collaboration is that we see these programs as an adjunct. They plug in. It's part of a community of care. At MESHA, we see the GP or the health professional really sitting in the driver's seat of some of that care strategies. What we do see is that the person who might be struggling with their mental health challenge, they are the ones that we do see in control of, they make the decisions. So if people come to MESHA that ask about our programs, we tell them, then the choice is entirely theirs. The GEARS program itself, and I've got some flyers over here as well, so you're welcome to take those as you leave. The GEARS program, like I said, intentionally group-based, 8 to 12 people. The reason why we put it in group is because one, it breaks down the social or cultural stigma that we're finding that does occur. And when we say group, it's police, fire, ambulance, Army, Air Force or Navy, all in the same room. Different colour uniform, fundamentally the same reasons why they joined in the first place. They wanted to be of service to the community. There's certainly a lot of crossover. The other part, or the other main reason for it being group-based, is because we're dealing with a cohort of people that operate best in teams. So if we can bring people in, and I've only just met with a couple of people this week who said, I'm not sure that I necessarily need the program, but I think I can offer it some support or help to those that might be in the program. I don't really care what their main intention is to come into it. Ultimately, I know that they're going to get some benefit from it. It is 12 weeks, 2 hours per week face-to-face. So we host that at MESHA, which is just next door to the Jamie Larkham Centre. And they come in, they tea, coffee, biscuits, that sort of stuff. We're trying to create a community for them to connect back into. Again, certainly the cohort of people that we're talking about, certainly if they're not at work, it means that they've been often disengaged from their normal community. They might feel isolated, they might feel unsupported by their teams, they might be feeling weak, like they're not able to do the job that they wanted to do. So we're trying to recreate that and break down some of that stigma to say there's actually no harm in getting yourself back to work. Sorry, the other point there, the first 6 weeks of the program is around emotions, connecting back in with them. As a police officer, emotions got in my way. It was never beneficial for me to experience any emotion at all because it stops me from doing my job well. Over 10 years, it's hard to turn that back on again. So that makes it really difficult. When I go to a doctor and they say, you've got post-traumatic stress or depression, I said, no, I don't. I don't feel anything. I'm not depressed. How wrong I was. The following 6 weeks after that, once we've got individuals to understand how it is that they got to this point, the trauma, the environmental factors, the social factors, the shift work, the organizational factors that put them in that position as well. We then start to get them to re-engage with their emotions, why it is that they think, feel and behave in a certain way. And then we spend a second half of the program focusing on the impact that they are having on their relationships around them as well. Often one of the narratives we hear is, I have PTSD. This was certainly my narrative. I'm speaking from my own experience. This happened to me. I now think, feel, behave this way. Therefore, you all need to put up with that. That's not necessarily true. I can take some responsibility of myself and start reconditioning myself to be able to engage again with my wife and daughter and work colleagues and that sort of thing. Interestingly, at weeks 10 and 11, we actually invite partners into the room as well. And what we found, the connection for that is because we're in, again, a group setting, we create an opportunity for the group to hear from the family perspective. It could be wife, husband, could be a brother, parent, whoever it might be that is a significant other in their life, but it's important for us to get that support also for them too. Moving on, we've got Story Right and Mind Right. Both of these programs were developed, again, by peers. MESHA picked them up in around the same time that we rebranded to offer some more support into these two programs. Both of them are a one-day workshop, 9 till 4. Both of them, again, are in group setting, currently offered to military members. We're in the process of having some emergency services members look at the programs as well, so that we make sure that if we're going to say it's for the community, it's actually designed and led by the community we're saying it's for. Intentionally, they're off base, casual attire, and there's no rank structure as best as we can. That's an easy thing to say, but obviously I sit in this room knowing that there's another police officer in this room as well that certainly outranked me. Despite the fact that neither of us are still in the job, I still feel as though there's a rank thing there. So we acknowledge that. Story Right is a focus on transition from military life to civilian, and we're talking about work environments. We're trying to, in that one-day workshop, trying to get military personnel to start thinking about what it is that they might like to do if they weren't in the military. What career would they like to follow? Because there's a huge issue when people do get out of service, they find themselves in underemployment. People join service because they want to serve the community and attach themselves to quite a high order, if you like. For a soldier, if fundamentally you're there to try to protect the country. If you get out of that environment, trying to find another meaning that is close to or similar to that level of meaning in your life can be quite difficult. It's not to say it can't be done, but it can be a difficult process for people to navigate. We look at their skills, their experience, their qualifications. We look at how that might translate into a career interest of theirs. And we then try to identify gaps. And then hopefully we can put people in place to help them close those gaps so they find themselves in a better position. It was off the back of the story, right, that they realised that maybe getting soldiers or Navy or aircrew into a room and starting to think about life after service might be a little bit presumptuous. And I know certainly if you came to me when I was on my way out of the police and said, what would you do outside of the police? I said, I'd try and get back into the police. There was no second option. So Mindright was formed. And Mindright is now starting to talk more to the identity that comes with those roles. What is it about those roles that got you interested in the first place? Because if I tell you why I joined the police, all of those cliche things, I was going to save the world, protect the community, and do all these wonderful things. That's true. Police are not the only people that do that. I can still find meaning, I can still find purpose in the work that I'm doing. Hence the reason why I'm here in this shirt, doing this work. There's still the same level of meaning, same level of purpose for me. No longer, though, does my role make up my identity. So SAPOL paid me fortnightly because of who I was. They gave me the uniform because of who I was. The uniform and the pay and the badge didn't make me who I am. It's just a different way of thinking. And that's the purpose of Mindright. Just trying to get people to connect back in as to take out the role. What are you trying to achieve while you're here on this planet? And what other roles could you do? The future for Military and Emergency Services Health Australia, MESHA, is still one that's being built. All of the GEARS facilitators are qualified or have accredited themselves either as with a diploma of counselling or with a Cert 4 in mental health peer work. For us, it kind of then makes sense that if we were going to upskill or ask for this paraprofessional workforce to develop their skills, maybe we could put them in positions where they could do more than just the facilitation. One of the things we're looking at is a lived experience workforce that are skilled as peer counsellors and could then serve as an adjunct again to certainly some of the specialist areas that we have. For us, we're talking about building that community so that we can offer some reprieve into some of the health professional space, but also offer another option for people as well. One of the biggest issues that we have, or that I have in my office is when I say to people, would you like to go speak to someone else, see a psychologist, psychiatrist, see a GP? I said, I've done that, I've tried that, I don't want to talk about it anymore. Okay, so why are you here? I said, well, you're one of us, you get it. That's a place for them to start. Trust and credibility is really difficult. And one of the fundamental successes for our programs is that when we close the door and we start running the programs, everybody in the room comes from a service background. If they have trust and if I have trust and credibility with them, I can then start talking to them about GPs that I respect or psychologists or psychiatrists that I've either seen myself or know that my community recommends them as well. That's what it is about for us. The programs beyond here, we are now starting to extend outside of South Australia. We're delivering some of the programs into Townsville. Once we start to build our workforce, we can start taking it national. Again, that's our intention. A significant focus for MESHA is on family support. So if we can, again, similar to what Nick was talking about, if we can start to engage the families and we can put resources and support mechanisms in place for them, then we know that there's a greater chance of the person who might be suffering in those conditions or those symptoms, putting them in a best possible way for getting them either back to work or finding purpose and meaning. Children is also another area. We're seeing a lot of those symptoms that the member is facing or showing are now coming through in the children as well. So we're trying to change that narrative and put support mechanisms in place for them too. And finally, all of the research that we're doing, if we haven't found another organisation that is already offering something into that space, we develop it ourselves, hence the GEARS program. We don't know yet what the rest of the future will hold for us as far as the research goes, but because we're independently funded, it means that we have really strong relationships with the stakeholders, certainly here in South Australia. And as they tell us issues, we can look into them. And if there's nothing there, we can then move on. We also have really strong relationships with Open Arms, RSL, Soldier On. We're trying to have a stronger relationship with SAPOL. We have a really strong relationship with the MFS and SAS. But again, it's one of those things that it's a work in progress. Coming back to that collaboration, it's also important for us to hear from the community over this side, from the health professionals as well, because there's probably lots of stuff that we're not aware of. And that's what we're looking to do as well, is build a better connection, better relationship with the health space so that you can feed information back to us so that we know what we're missing, so that we can start filling some of the gaps to best support and put that collaborative approach around the support for the individuals. They're my details. I've got some cards over here. So if anybody wants to pick this conversation back up again at another time, you're welcome to. If you do have people that you think might benefit from the GEARS program, from MindRight, or from StoryRight that you are seeing, again, some emails up through there. Welcome to take the phone calls and the emails as well, if you don't get that detail down now. Cool. Thank you very much. Appreciate it. Questions?
I'll just make a point. One of the cool things as a psychiatrist is seeing a lot of these programs actually being looked up by the guys themselves. Not only this, but there are programs being led by Ben Wadham, Associate Professor at Flinders Uni, which is looking at re-engaging vets and coppers back in the tertiary sphere. That's now extended to linking to industry. So these ideas have grown from the grassroots up. They're not being imposed from government. Nothing wrong with government, but there's a lot of ownership of these programs, which has been awesome to see. That's it. Questions? Any questions?
Couple of questions.
You asked, yeah, it was marginal, but anyway, yeah.
Does the personality that becomes a good cop or someone who is it a pre-morbid condition that people who choose to go into these occupations or these professions, is that predispose you, make you at high risk? Or is it only the environment?
We'll both answer that.
Yeah, well, I think from my perspective, I had a relatively straightforward, normal upbringing. My schooling was all geared around my intention to join the police. I joined as a 20-year-old who was looking to make a difference and change the world. I didn't have a great deal of, I guess, other work experience. I did have some life experience, having lived interstate for a brief time. Hard to say, I guess at that age, I joined at 20 and then death and destruction and like human depravity becomes the norm. I'm not sure. It might be best a question asked of maybe someone who joined the police or a service role later in life.
There's a couple of aspects to that. I think a lot of what we choose to do as kids is based on the experiences that we've had around us. A lot of docs and nurses have docs and nurses in their family. One of the things that I often see with military is that there's somebody in the family, an uncle, a father, a grandfather, a second cousin twice removed, who's influenced the kid to move into that. Now, I think it's fair to say that people who are going to those high-risk professions are going to have an overabundance of adventurousness. They're going to have a little bit of dependency built in because you wouldn't not be dependent if you're willing to put up with some of the things that happen. There's nothing wrong with dependency. It's just too much of it's a bad thing, I guess. There's another really interesting statistic, and it doesn't so much come from us, it comes from the Americans, that one of the best cures for naughty street kids, particularly with gang involvement, is 5 years in the US military. That figure goes back to the 1980s because what you're getting is a set of expectations, a set of nurturance, being yelled at by your sergeant, who at least probably cares at you, is a form of nurturance. So there's a whole bunch of things with that. It provides a framework, and often a very good framework, for people to mature. But a lot of it is based, we do what we see around us. We do what we see as valuable.
We've just got a comment from online. as a veteran GP up in Mackay, sorry, I can't pronounce where it is.
Hi, Kerry.
Yeah. I'd love to see these programs expanded nationally, if you've got any comment on that.
Kerry, I think I should refer that to Matt, who's been an awesome ambassador, but nice to hear from you.
I'll use this one. So the intention is for us to take the programs nationally. One of the important parts that we need to focus on, though, is making sure that any growth is done in a controlled way so that we can preserve the integrity of the programs as well. So we have had a number of interest from, I guess, other professions that are wanting to get involved. They could be counsellors, psychologists, GPs who are already delivering programs, but might not necessarily have a service background themselves. Now, at the moment, we're reluctant to bring those people, those professionals into this space because we're still recognising that the reason why one of the big barriers for people to come into any program is knowing who's going to deliver the program. So I think even when we've had a number of return to work agencies that will bring someone that they think would really benefit from the program, but won't sign up, and so they bring them in. And then I talk to them and just say, you are like the 200 other military or emergency services members who have come through and done gears and said the same thing. I can say that because I too was one of them. This is not for me. I'll come and check it out. I might be able to offer something to the group. I'm talking about a group of people who are trying to be of service to their friends and service to their community. So for us, if we can find more facilitators for the programs, wonderful. But for us, we're still pretty particular about who our facilitators are to make sure that the people we're servicing get the highest level of I guess, support.
So in relation to the question about are police and service people at more risk because of going into that environment because they want to help, Matt said something in your presentation about we can put up with a whole heap of garbage if it's in context. And I think part of the context that people don't anticipate is how management are going to manage the people. Is there any views on that?
When you say management, is that the organisation management?
The organisation management, yeah.
Sure.
How they manage the people once they start having issues and investigations and the rest of it.
Yeah. Significant. We're certainly talking about an issue that is managed from both directions. When we start talking about some of the service organisations, though, the culture starts at the top. The expectation, the reason why I didn't say anything when I was in the police, of why it is that I'd been diagnosed and that I needed help, is because I was fearful of how I would be treated and what would happen to my career, that I'd be taken off the road, that I'd be put in an office. Now, that might not necessarily be true for everybody, but I've seen it a lot. So I think when we start talking about the stigma that occurs and the impact of organizational structure and management, you know, in a lot of cases, I'd almost rather go into a crook's house not knowing what's going to be there than maybe walking into a boss's office. So I think it's a really important point you raised, Derek, around how, management impact, you know, the support and even help seeking barriers as well. But Nick, you probably have experience in that as well.
Yeah, look, it's a massive factor. And, you know, I've had different experiences with SOPOL, but I've also seen the ugly stuff. There was one battalion a few years ago nearby here. When I got a soldier from there, I just sort of sigh and just say, game over. There are other units where I've had soldiers come from them and it's kind of, you know, woohoo, we'll get this guy back. One of these guys was in hospital a year later. He was in Afghanistan where he performed creditably and has come back and happy married father of 2 kids. I know all that because I treated one of his friends. Leadership is vital. And, you know, there's the human cost, but at the very least, you're dealing with $200,000 worth of the country's money. It's crazy not to treat it well. Yep. You were first.
Oh, sorry, Lisa, thank you. Matt, just about your programs, is there a waiting list or is there a particular intake time?
Yeah, we do have a wait list. We do have courses. Gears kicks off on the 3rd of August here in Adelaide. We've got 2 programs here. We're also doing one online as well and one in Hobart. So Dr. John Lane, who developed the program, he lives in Hobart, so it makes it pretty easy for us to put programs on over there. And then StoryWrite and MindWrite, we have a MindWrite course coming up on the 30th of July. And then we've got the StoryWrite following on the 6th of August. But if, there's still a wait list then, and obviously demand will then determine supply as well. So the last groups that we ran earlier this year, we didn't really advertise because we did have a bit of a wait list. And a lot of it is just word of mouth. It's not us doing this. Well, Nick has certainly been quite influential in getting people to come along to the programs, but then once they come, they then tell their friends. They're like, you should go do this program. Yep. And then obviously the 14th of August, we have the half day workshop again, where Dr. John Lane will actually be here flying in, COVID permitting. We'll start to be able to talk a lot to those points as well. Yep.
So I have a question. Sorry. Yeah. Can I? Sorry. So I have a question. As a GP, we discussed about like picking up the early signs of PTSD and behavioral changes, but being a mother of a child, like a young man who has joined Army recently, and I'm a veteran's child myself, my father being in the Army. So I don't know, as you said, there might be hidden agenda or hidden reason for that, for young generation to join. But what I want to know as a mother, of course, and as a GP now, so here in Australia, but he's in US. But I want to know, is there any, like, have you come up with anything that we can detect, like the way to prevent rather than, pick up early sign? We don't wait till this PTSD happened. We don't wait till this anger issue happens. So we prevent it from happening, because a lot of young folks, they're still joining, veteran, like Army, and police, to become a police officer. So is there anything we can do as, preventive measures, like to, prevent this from happening? So because that would be more effective rather than waiting this to happen and then treat it. Is there any way or any, welcome package for Army or something like that? Mm-hmm.
So I'll talk about my experience. And I think when we start thinking about the role that we're talking about, so in my case, police officer, a shift worker, the longer I stayed in the job, the less engaged I was with my outside community, because I was no longer invited to, catching up with the guys on a Saturday night, those that had 9-to-5 jobs, because I wasn't available. So you only get so many no-shows before you stop getting invited. The other interesting thing that happens as well is that the further you get into that, for me, hearing someone's version of a bad day was very different to mine. So even when I came home and my wife had, say, been at work, and she would say, I had a customer that yelled at me. So, okay, in my head though, it's like, well, I just had someone who held a scalpel to their neck for the last 3 hours, threatening to blow the house up with their children inside. Perspective is difficult there. The changes that occurred in my life, friends have since said to me, I saw you at that job and you were a little bit different. One of the things that I say is, like, if we saw a dying plant in the corner, we would probably have a fair few ideas as to what's wrong with it. The reason why we would think that there's something wrong in the first place is because we know what the plant should look like in the first instance. Hopefully people are coming to GPs and health professionals on a regular basis, you'll start to get a benchmark norm. As a mother, you'd probably have a fair idea as to what normal, I use that term loosely, looks like. When we start to deviate away from that, some of those things can be picked up quicker. So what I say to people is, you cannot underestimate the impact that you would have as being an expert in your friend, your family, your colleague, or maybe a patient's life, is recognizing some of those small changes. Some of it can be the language that's used. Some of it can be the disconnect from emotion. For me, I have family members that say the stories that I would share that I found amusing were horrifying, like to them, when I said them out loud, and obviously I don't need to share any of them here, but for me, that was like, well, what are you talking about? Like, all of my mates at work laugh. So then I just disconnect more from them and then stay over here. So there's a lot of that goes on. I would say just be very attentive. And if something doesn't feel right, like if my wife was here, she would probably be able to answer that question a lot better. But if something doesn't feel right, say it. Yeah.
One of the key things, I think, is letting people know that you're grateful that he served. The number of guys who don't tell their families what they've experienced for fear of contaminating them or horrifying them, when generally the family is quite receptive to sharing some of that. And I can wax on into mythology here. Apparently in ancient Greece, when there was a fight, the soldiers would come back and there was a purification ceremony miasma, not just the soldiers, but the whole community, because we're all involved in that. Yeah. But, you know, and I guess as a mum, you know, asking your son, is he okay? You're not going to get too far, or at least with my kids. But these things usually happen in periods of silence. They usually happen with an appeal to basic needs, cups of tea, that sort of stuff. And it will come out gradually, but show you're interested. Yeah. Good luck. Good luck with him.
Matt, with the groups that you run, and as you said, a lot of it is the cohesiveness of being back in a group and the safety of that group. What sort of follow-up do you do when the group ends? Like, for example, after a 12-week program, do you have any data to say what happens to those people?
Yeah, so the program itself, the Gears group in particular, is underpinned by Dr. John Lane's PhD research, which means that there is post-course follow-up from that perspective, which is still being analysed. It's been occurring for the last couple of years, and John would probably be the best person to talk to those results on the 14th. From a practical point of view, though, what we have seen is that a lot of the people who come into the programs then go on to form their own little groups outside of that. So the last groups that we ran, the group then went out for dinner a couple of weeks later because they found that they weren't getting enough conversation time because I kept interrupting them to talk about the content, you know, which is what we wanted. We wanted this like community engagement, and we went from having people who, you know, one particular guy who'd served many, many years in the military and struggled to even go to his letterbox because he knew that he could take someone out from a very, very long way away. He thought if he could do it, then someone else could too. So he had this playing on his mind. Was now taking his motorbike along the coast to go home, and then was coming back out to meet with some of the people he had connected with in the group for coffee and meeting at cafes. So we know, I guess, anecdotally that there is a community that is being formed. But I think the point that you raise as well for us goes back to the importance of you in the room as well. Is the reason why we have a GP referral or a health professional referral is so that we know that there's an ongoing community of care that's available to them. We have had people come back and do the Gears program again. They've just re-enrolled in the next one. That's entirely okay as well. So sort of two answers there. There is research into it, yeah, and we are showing that there is like positive results as a result, which is good. But then also anecdotally, just from that human connection point of view, we're getting people out of the house that might not have otherwise come out of the house. Yeah.
We just have another online question. How do you see veterans' mental health now that Australians have withdrawn from Afghanistan and reports that many Afghan nationals are surrendering to the Taliban, etc.? Do you feel like it will exacerbate the sense of what was the point?
I'll start. I can obviously only speak as a police officer though, but I think when we start to raise those questions around what is the point, it goes back to leadership. It goes back to really highlighting why it is that any job for that matter, whether it's a 20-year war or it's a siege on a house, you know, that was only caused so that we could take the children away, only for them to be returned back to the same house, to the same family the following day. It does raise that issue around, well, what's the point? I think it's, again, goes back to some of those fundamentals around us as a society, recognising the service that's been put in. Also then trying to make sure we've got appropriate support mechanisms so that people still understand why it is that they did that job in the first place, and that they still have meaningful connection to that and anything post-service as well. You want to talk to it?
Yeah, the pullout's certainly messing with the people that I've seen. There's been quite a bit of a discussion about the futility and the hopelessness and why were we there. It kind of really tracks into a lot about what these service professions are. When you sign up to join the army, you basically sign up to do anything your country wants you to do. Go and rescue flood victims, go and count penguins on Macquarie Island, or go and defend the national interest. Now that's an incredibly honourable thing to do, whichever way you put it. What's happening over there? You know, from a national interest point of view, government's made a decision. I think we were over there for alliances. There are all sorts of reasons that are way above my pay grade. From a personal perspective, one of the things that I think is really getting under guys' skin, certainly getting under mine, is the guys who helped us over there, the translators, the foreign aid workers, the infrastructure workers, who are going to die. This is a big country. We need more people. We should be getting over here. There you
go. Thank you very much for your presentation. I wanted to ask you particularly about the Defence Force space and what we can do better while they're still serving. At the moment, if you join the Defence Force, you're screened beforehand, including by a psychologist. Before you go on deployment, there's a lot of work in terms of the activities that you can do with building resilience, and there's Battle Smart and so on. And I think the cohort studies generally show that while serving, the mental health of ADF personnel is much better related to that sense of purpose. But and following deployment, there's often sort of extended involvement with psychologists and so on. But I just wonder, you touched on, is it there's a gap in what's happening while they're deployed, or is it the nature of the service with the sustained operations in Afghanistan or the border protection role or things like Rwanda?
Yeah, so it's a really interesting point you raise, because the police, same sort of thing. You still meet with psychologists, you still have all the various psychometric testing to get in, and we take those from the community who are deemed to be maybe like in a certain percentile, and then we go and expose them to really horrific and traumatic experiences, and wonder why things work out the way they do. I think there's a couple of points that we're getting better at it. Mental health literacy. I think we can't also forget the fact there's a level of self-responsibility as well. As an individual, like me as a police officer, being in the police, I still have a level of responsibility to manage myself, at least to some level. Mental health literacy is really important. And so for me, I wasn't able to pick the fact that I wasn't sleeping properly, that I was relying on alcohol, that I was waking in the night. I didn't understand any of that. And when I was diagnosed, I refused the diagnosis and said that it's not for me, because I never went to war. So I'm not going to take that label. That's not fair on those that did. And like I said to you before, I didn't feel depressed, so therefore depression is not mine. That's a self-understanding. The big issue that I think for me that I experienced when I got out of the police, and it happened quite suddenly, 7th of August 2015, was the last time I wore a uniform, was the complete loss of identity. I didn't know enough about who I was beyond service. And so I think whilst I was in service, I still felt as though I belonged somewhere, that I had a sense of meaning and purpose. I think that's one of the critical things, is as we have moved members out, it took them 12 months to condition me to get ready for the job. And it took them about 45 minutes to get me out. So when you start looking at the significance of that with zero support afterwards, now we are getting better at transition processes and putting programs together, and DVA do the same as we're trying to get people out. But I think fundamentally we need to be starting to address some of that identity, meaning, purpose as we're starting to transition out and getting people ready for what that looks like.
Yeah, the issue of mental health on deployment's a really important one. The RTAP screening when the guys come back, the ones that I see routinely tell me that they lie through their teeth because they know if they screen positive that they will be moved out of the military. Now that's maybe taken a little bit of improvement over these past few years, but not so great. Being at war is, it's fun. It's exciting. It's dangerous. That there's a lot of focus, and really you don't have to think too much about anything else. Most of our deployments are around 6 months. I've got one guy who was over there for 18 months doing all sorts of very, very dangerous things. And the fact is he's seeing me. An issue that comes up from World War II, there's a really good number. The British Army had it worked out in North Africa, where my grandfather was, that the average soldier, a soldier could last 73 days on the front line, after which his performance decayed so that he became almost useless. I think the Brits disbanded a whole division, the Wessex Division, because of mental health casualties. So those guys will wear out. And I'm sure if you've been involved in adventure sports or things that are involving fatiguing, you'll see guys walking around shambling, fatigued, exhausted, simply not able to function. But getting them back, one of our successes after Vietnam was actually keeping the guys together. And I think a lot of it, I would say the success involves around the group's acceptance of the guy coming back. But then you have phrases being used like, he's a liability or he's a morale vampire. Morale vampire is a good one. And it's how the group actually accepts that and sees that. Yep.
Just a comment from online to say, yes, it is very shameful to leave the interpreters over in Afghanistan.
Looks like we're done. Really, thank you all for coming and showing interest in this topic, which is obviously very dear to me and Matt. And yeah, keep in touch.
Just to close, just a reminder to everybody with your evaluation forms, if you can fill those and get them in. And also, I believe rubbish has to go into the bins at the back, if you could, please. Thank you very much, Nick. Thank you very much, Matt.
And everyone, don't forget to sign up for the August the 14th session. You can find information about that session on www.satmea.asn.au. So thanks, folks.
Okay.